Neonatal head ultrasound is best performed in the first 6 months of life when the anterior fontanelle is about 20 to 40 millimetres. Indications for neurosonography in preterm and term neonates include prematurity. Generally, preterm refers to delivering prior to 37 weeks, whilst a premature infant is one that has not yet reached the expected level of fetal development. Increased head circumference, meningitis, fitting, trauma, perinatal asphyxia, follow-up of known pathology, delayed development, suspected intracranial mass, hemorrhage or infection, congenital abnormalities, persisting large fontanelle or craniostenosis. The following pictures highlight important neonatal brain anatomy. When we begin coronal imaging through the frontal lobes, the orbital ridge forms the inferior boundary of the image. As the transducer is angled back, the cerebrospinal fluid in the lateral ventricles results in these dark structures. The lateral ventricles are larger in preterm infants than in term infants. Asymmetry between the lateral ventricles should be noted, but is not always abnormal. The cavum septum pellucidum, shown in green, sits between the lateral ventricles and is often large in preterm infants. The corpus callosum, shown in pink, appears above the cavum. With the transducer shifted slightly further back, the third ventricle, shown in blue, appears below both lateral ventricles and the septum pellucidum. It is often small and difficult to see, but can vary considerably in size. The foramen of Monro, connecting lateral and third ventricles, may be clearly seen. Angling further back cuts through the trigones of the lateral ventricles. The choroid plexus, shown in yellow, fills the lateral ventricles in this view and is prominent in preterm infants. Choroid plexus hemorrhage may be difficult to differentiate from bulky choroid. The white matter around the lateral ventricles may appear quite echodense in this plane. Angling the transducer even more results in an image that slices above the lateral ventricles. In this plane, the occipital cortex may be visualised. Neonatal head ultrasound should include the following coronal views. 1. Frontal lobe. 2. Anterior frontal horns of lateral ventricles. 3. Body of lateral ventricles. 4. Level of posterior clinoids. 5. Level of circle of Willis. 6. Basilar artery level. 7. Fourth ventricle. 8. Tentorium view. 9. Occipital horns of lateral ventricles. 10. Posterior fossa. The following table outlines some of the structures that will be seen in each of these views. This slide highlights important neonate brain anatomy in longitudinal views. Midline longitudinal identifies many useful landmarks. The cerebellum, in orange, shows up as an echogenic structure in the posterior fossa. The fourth ventricle, shown in light blue, sits in front of this. The cisterna magna sits below the cerebellum and is not very echogenic. The corsum callosum in pink is seen sweeping from anterior to posterior with the cingulate gyrus above and parallel to it. The parieto-occipital sulcus is seen well above the posterior fossa. As we angle parasagittally, the shape of the lateral ventricle, shown in blue, is the key landmark for this view. The caudate nucleus in purple lies below the floor of the frontal horn of the lateral ventricles. The thalamus in green lies behind and below it. The occipital horn of the lateral ventricle is filled with choroid plexus. The choroid tucks up in the caudothalamic groove in the floor of the lateral ventricle and may be echogenic. Further angulation of the transducer laterally results in a section lateral to the lateral ventricles. The Sylvian fissure is the key landmark in this view. In very premature infants, the brain sulci are not fully developed and the brain appears quite smooth. Neonatal head ultrasound should include the following longitudinal views. 1. Midline. 2. Thalamus, approximately 15 degrees off midline. 3. Lateral ventricles, approximately 30 degrees off midline. And 4. Lateral. The table shown on this slide lists the structures seen in each view. Additional views include a linear of the subarachnoid space. The shortest distance between the cerebral cortex and triangular superior sagittal sinus should be less than 10 millimeters. We should always attempt to demonstrate distortion or asymmetry associated with any pathology found. The posterior fontanelle may be used to image the occipital horns. Other windows include the parietal or temporal regions. Calipers must accompany ventricular dilation. Measurements are the same as in utero, therefore should be under 10 millimeters. The germinal matrix is a frequent site for hemorrhage in premature babies and should be looked for in the region of foramen of Monro and the head of the caudate nucleus. We'll discuss this more later. Serial sonography is required to monitor developmental progress and or pathology. An example of this would be day 4 and 7, all infants to be scanned. Day 14 and 21, infants with grade 3 or 4 intracranial bleeds. And day 30 or pre-discharge, all infants should be rescanned. Intracranial hemorrhage classification according to Papil. Grade 1 is hemorrhage limited to subependymal matrix. Grade 2 is hemorrhage extending into the ventricular system, less than 50% without acute ventriculomegaly. Grade 3 is hemorrhage extending into ventricular system with acute dilation because of flooding of 50% or more of one or both lateral ventricles. Grade 4 is hemorrhage grade 1, 2 or 3 with extension into the brain tissue. The germinal matrix hemorrhage is the most common type of bleed within the brain of premature babies, usually occurring 24 to 28 hours post-delivery. It is caused by a rupture of the fragile capillaries of the subependymal matrix at the site of the caudothalamic groove. A grade 1 subependymal hemorrhage is confined to the germinal matrix. It is seen on ultrasound as an echogenic region at the caudothalamic groove, usually 2 mm to 1 cm in size. A grade 1 hemorrhage may completely resolve, leaving subependymal cysts, or it may worsen and progress to grade 2. The majority of grade 1 bleeds completely resolve without neurological deficit. A study by Whitaker found those who had germinal matrix hemorrhage were at an increased risk of current major depressive disorder and obsessive compulsive disorder. Grade 2 intraventricular hemorrhage without dilation. This is when a grade 1 bleed breaches the walls of the ventricles. Early on it is seen as a dependent echogenic blood layer within the occipital posterior horn of the ventricle. The third and fourth ventricles become more prominent. A grade 2 hemorrhage may resolve or it may progress to grade 3. A grade 3 intraventricular hemorrhage is with dilation, therefore we see ventriculomegaly. This expansion is caused by bleed directly or blood clot obstructing the aqueduct. It can be treated with drugs, serial lumbar punctures, or with a ventriculoperitoneal shunt. It may result in motor deficiencies and some mental retardation. It can remain stable, resolve, or progress to grade 4. Grade 4 intraparenchymal hemorrhage is when a grade 3 bleed with ventriculomegaly then extends into the brain tissue, usually the periventricular region. 59% of these hemorrhages result in death. 86% result in permanent physical disability and 64% with mental disabilities. This begins as an echogenic homogeneous lesion with irregular margins. 1 to 2 weeks post-hemorrhage, the centre will become anechoic as the clot resorbs. 2 to 4 weeks post-bleed, the edges become well demarcated as the clot retracts. By 2 to 3 months post-bleed, it appears completely anechoic as a result of necrosis. Porencephalic cysts may remain. An intracerebellar hemorrhage is most common in premature babies. Cerebellar hemorrhage produces either ill-defined asymmetric cerebellar echogenicity or a focal mass. The hemorrhage may resolve completely or produce an area of encephalomalacia. Subarachnoid and subdural hemorrhage is sites of hemorrhage in term infants. The ultrasound appearances include fluid collections, widened interhemispheric fissures, visualization of cortical surfaces, and mass effect with flattening of gyro, as well as displacement and compression of ventricles. A choroid plexus hemorrhage is most common in term infants. On ultrasound, it appears as enlarged echogenic plexus with lumpy contour. An encephalocele is a herniation of meninges or a portion of the brain through a hole in the midline of the skull. According to RUMAC, 75% are occipital, but they may occur in the frontal or parietal regions. It is usually entirely fluid-filled, but may contain small amounts of echogenic brain tissue. It appears on ultrasound as a cystic mass at the surface of the skull, commonly in the midline. Encephalocele may be part of Meckel-Gruber syndrome, which is a lethal autosomal recessive disorder characterized by occipital skull defect, bilateral polycystic kidneys, and polydactyly. Hydrocephalus is a dilation of the ventricles associated with an imbalance between production of cerebrospinal fluid and its drainage, resulting in a build-up of cerebrospinal fluid. According to RUMAC, hydrocephalus occurs in approximately 5 to 25% per 10,000 births. Causes include obstruction to outflow, for example, vein of Galen malformation, infection or hemorrhage, overproduction of cerebrospinal fluid, which is rarer. An example is choroid plexus papilloma, decreased absorption, or post-intraventricular hemorrhage. Hydrocephalus can often be diagnosed in utero by 15 weeks gestation. Our upper limit of 10 mm for the ventricular atrium applies. Ventricular size is slightly larger in newborns than in older children. Once recognised, close inspection for spinal dyspraxium, other CNS or extra CNS abnormalities is warranted. Chromosome evaluation is necessary if other abnormalities are recognised. We should look for signs of Chiari-2 malformation, as this is almost 100% associated with a myelomeningocele. If obstruction is the cause, we need to identify the level at which there is transition from a large to a small ventricle. If we have dilation of the lateral and third ventricles, it's generally an aqueduct of sylvius obstruction. If we have dilation of all the ventricles, this is generally an extraventricular source. Outcomes are variable. Often, especially if other anomalies are diagnosed, the families choose to terminate the pregnancy. A shunt can be placed to decompress the ventricles. We can use Doppler to assess intracranial pressure and help determine the need for shunt placement. Ultrasound should be used to follow up the progress of this shunt. A recent study by Whitaker found that parenchymal lesions and ventricular enlargement increase risk for current attention deficit, hyperactivity disorder, tic disorders, and obsessive compulsive disorder. Between the 4th and 8th weeks of gestation, the primitive prosencephalon should divide into the telencephalon and diencephalon. Failure of this diverticulation results in holoprosencephaly. There is a spectrum of malformation from the most severe with no separation of the telencephalon into hemispheres, this is known as alobar, to the least severe with partial separation of the dorsal aspects of the brain, known as lobar. The septum pellucidum is absent in all forms. Alobar is the most severe form, and infants usually die in the first few months or are stillborns. Severe facial deformities are present. Sonographic findings include a single midline crescent-shaped ventricle, a thin layer of cerebral cortex, no falx interhemispheric fissure or corpus callosum, fused thalami and basal ganglia, fused echogenic choroid plexus, an absent third ventricle, and a large dorsal cyst. In semilobar, we may see separate occipital and temporal horns, a small portion of falx or interhemispheric fissure. Splenium genu of corpus callosum may be seen. The thalami are partly separated, and facial anomalies are less severe. Lobar holoprosencephaly is the least severe form. We have nearly complete separation of the hemispheres. The septum pellucidum is still absent. Anterior horns of the lateral ventricles are fused and square. The occipital horns are separated. The third ventricle is usually present. Facial anomalies are mild.